All right. Hi, everybody. Let me just make sure my volume is okay. Yeah, we're good. All right. Welcome. We have another webinar for you guys. And let me get this picture. I just feel like this picture needs to be centered. Welcome. I am really excited to share this webinar with you guys today. I've been using cognitive behavioral therapy with eating disorders for, well, really since the beginning of treating eating disorders for me, which was 2007. And even though I kind of do different versions of it now, especially working outpatient in private practice when maybe not everybody's coming in once or twice a week, it makes doing CBT a little bit different. And so I just really love using the main tenets of cognitive behavioral therapy, and we certainly know it's evidence-based for a variety of eating disorders. So want to introduce this to you guys today. Let me go ahead and share my screen so we can get going with the PowerPoint. All right, and I will play this. All right, here we go. Okay, perfect. All right, so I don't even think I introduced myself. My name is Meredith Riddick. Like I said, I've been working with eating disorders since 2007. I initially began working at higher level of care residential treatment for adult women with anorexia or bulimia. And then in 2009, I moved back home to my hometown of Houston and opened a private practice. And I've been treating eating disorders, all different ages, genders, since that time. And this year in 2019, I'm actually relocating to Virginia, where my husband got kind of the job of a lifetime. And so we have decided to move there and live there permanently. And so I'll be moving my practice there. But the cool thing about doing webinars and doing virtual sessions and all that is that it doesn't even matter, you know? So this is really cool. So let's get started looking at cognitive behavioral therapy and eating disorders. Oh, one thing I do like to share in all my webinars is want to make sure this is just educational and informational. By no means is this meant to be therapy for anybody or supervision. If you are a provider who treats eating disorders or someone who is wanting to learn how to treat eating disorders, there are so many different nuances and complexities in working with eating disorders. There's no way that I could know about you or a friend of yours or your own client to give you any kind of direction. So this is really just meant to be informational and educational. All right, this is my favorite definition of an eating disorder that I heard a really long time ago, and I wish I knew who to attribute this to, but for the life of me, I have no idea. But it goes like this: eating disorders are irrational and unhealthy means of meeting rational and healthy needs. And I love that because there's so much in there. I think, you know, a lot is said in the irrational and unhealthy means. Ultimately, the behavioral part and typically the thought part of eating disorders are problematic, and they get to a point in a person's life where they're interfering with physical health, mental health, relationships, that kind of thing. At the same time, too, especially emotionally, we have rational and healthy needs. So a lot of times eating disorder behaviors, you know, serve the purpose of trying to meet those needs. And what we can do, especially in cognitive behavioral therapy, is kind of determine what are the thoughts and behaviors that are going on, maybe triggered by certain emotions that are getting in the way. That how can we look at this emotion and probably validate this emotion, right? Because all emotions serve a purpose, and begin to change the way that we behave and think about a situation. Or it could be certain things are causing us maybe even more emotional distress than maybe what a situation calls for. So we can look at how can we change our thoughts and our behaviors to have less emotional distress in our lives. So these are all really connected. There are many functions of an eating disorder. These are truly just tip of the iceberg. But when we talk about the function of an eating disorder with a client, you know, we're often looking at what are those unmet needs in that person's life? What are they going for? And looking at all of these, right? A sense of achievement, to gain a sense of control, to deal with the effects of trauma, attention, the sick role, maturation fears, social acceptability, dealing with shame, there is not a single thing wrong with any of these functions, right? We just need to kind of help an individual understand what the function of their eating disorder is, why it's that way, what's the unmet need related to that function, and how can we learn how to get that need met. I think about even something like the attention or the sick role of an eating disorder, and this might be someone who says, maybe this is someone who's the oldest sibling out of, 5 or 6, and they say the only way I ever get any attention from my parents is whenever I'm sick, is whenever I'm struggling with the eating disorder. And so even though we can kind of throw around statements, oh, she's just doing that for attention, it's kind of like, well, yeah, she's doing that for attention, because receiving attention is a pretty basic need that we all have. There's maybe a spectrum of that need, but at the end of the day, especially as babies, if any of us went ignored or had very little attention, we would very much be impacted psychologically through that lack of attention. Maturation fears, I often see clients who are especially in their teens or young adults who are highly perfectionistic, highly anxious, and they are so afraid of kind of adult responsibilities. Even this was a long time ago. I don't know if this is as relevant nowadays, but a long time ago, I had a client who was so afraid of kind of growing up because she didn't know how to write a check. And so being in the eating disorder, right, is something that it's, we get treated as younger than we are. People take care of us, we don't have to do certain things. So you don't have to take this course, you don't have to do this sport, you don't have to do this homework, right? And so a function of an eating disorder and maturation fears might be helping that person kind of avoid growing up, in a sense. So if we can look at that and validate, yes, growing up is hard, and there's aspects about being an adult that is really hard, but if we can look at that and lean into that and kind of reduce and eliminate those eating disorder behaviors, and instead find other behaviors that help that person feel more confident in growing up, then we're working on recovery, right? So this is probably the most basic tenet of CBT, is basically the CBT triangle that essentially says our thoughts, feelings, and behaviors are all interrelated. What we think affects how we feel and act. What we do affects how we think and feel. And how we feel affects what we think and do. So CBT maybe looks, it's very similar across the board, but it might look a little bit different depending on the eating disorder. We're only going to be going over anorexia, bulimia, and binge eating today. And I just want to quickly differentiate, because if I go into all the diagnostic criteria, oh my gosh, that's a whole nother presentation. So with anorexia, we're typically looking at someone who's significantly underweight for their normal weight and body type and age and height and all that good stuff, right? And with anorexia nervosa, there's restricting type and there's binge purge type. So someone who's significantly underweight, who is restricting their intake, whether it's types of foods, whether it's amount of foods, whatever, and possibly who does compensatory mechanisms like purging through self-induced vomiting, or who also binges. A lot of times we miss that part. We don't know, it's not common knowledge that individuals struggling with anorexia nervosa may also binge. So that's kind of one of those subtypes. Also, it could be someone who overexercises a lot, right? So that's kind of what we're looking at there. So in traditional kind of manual-based CBT, it's typically going to be 3 phases lasting about 1 to 2 years. In true manual-based CBT, which I don't do true manual-based, you're looking at, for the first 8 weeks, it's going to be 2 sessions a week and that kind of thing. So it's very specific how many sessions per phase. With anorexia nervosa, there typically is a longer length of time to overcome motivational obstacles, because behaviors like restriction in particular are very egocentric. They feed the ego. Someone often feels really good emotionally once they are restricting, losing weight, that kind of thing. And also you may have experienced in your own recovery, or you may have a client who's experienced this, especially in the initial phases of the eating disorder, and someone's losing weight, they get a lot of compliments for it, right? So it's kind of like motivational obstacles of why would I get better? I'm getting all these compliments, right? Achieving appropriate weight restoration can take some time, and also within the course of anorexia nervosa may need higher levels of care during this time frame. But in phase one, as a therapist, you're really working on building trust and setting treatment parameters, just kind of meaning giving some structure to this therapy, helping the client know what to expect in terms of time frame and what we'll be working on, that kind of thing. In phase one, you're meeting regularly, preferably at least on a weekly basis. You're working on a positive therapeutic alliance. So there's certainly a relationship component to all of this, right? We're not just kind of setting a book in front of someone. Well, there's not really a book here, but we're not really setting a book in front of someone and, you know, telling them to here, do all of this. We're building a relationship. We're getting to know our clients, and we're getting to know you. We're getting to know your friends or your family member, and just kind of establishing a good relationship. We're assessing the eating disorder through weight, medical concerns, behaviors, weight and shape attitudes, also personality, which may include low self-esteem, perfectionism, low self-worth, just different aspects of that. We're also doing psychoeducation about behaviors and the function of symptoms. So a little bit kind of like I was saying before with the functions of eating disorders, right? There's an explanation of two different sides to the treatment. There's a behavioral theme and a psychological theme. In the behavioral theme, you're kind of getting rationales for treatment and weight restoration and cessation of behaviors, and kind of the reason for that. In psychological, you're going to end up going more toward, you know, the negative body image. There's in doing CBT, there's a lot of addressing cognitive distortions such as all or nothing thinking, and that doesn't just show up with food or body. That shows up in other areas of life. So eventually looking at how does, for example, all or nothing thinking impact relationships or your work environment, right? Going over recommended eating patterns. This is another way I deviate from manualized CBT. I always bring a dietitian into the picture. Maybe I should say almost always. Maybe there's, you know, a few exceptions, maybe because of finances or just something like that. But I almost always, you know, recommend seeing a dietitian. So my preference would be that a dietitian is the one prescribing regular eating patterns and not the therapist. However, there are therapists who do. Self-monitoring is a skill that has gone over in phase one, and I will show you guys that. And the other important piece that we're doing in phase one for anorexia nervosa binge purge type is we're interrupting that binge purge cycle. Also in anorexia, it could be binging or purging, okay? So monitoring. This is typically completed on paper, but now we have some really amazing apps. I like to use Rise Up because I think it's a really comprehensive app, especially if I'm doing CBT with a client. And they can also, it's free to use, and they can also email me or any of their providers their like a weekly summary of what's been going on. Recovery Record is also amazing to use. I personally just don't use it simply because they do charge the clinician to kind of get the data. And as a therapist, I'm not really the main one who gets all that data, but I know a lot of dietitians who love using Recovery Record. The purpose is information gathering. It's not necessarily focusing on behavior change at this point. So we're really just getting information for a brief period of time, a week or 2 weeks max usually. So the client is going to track multiple times a day the food consumed, eating disorder behaviors used, thoughts, emotions, and other details about meal or snack time, such as the day, the location, maybe who they were with, something like that. One of the reasons that we just want to do this temporarily is so as not to increase obsessiveness or rigidity. A lot of times individuals with anorexia nervosa perhaps are already doing their own version of self-monitoring, and it's really increasing obsessiveness. So we're only doing this for information gathering and to kind of help the client see patterns of what's been going on, but we don't want this to last a long time. So here's maybe an example of what this could look like, right? So maybe this person eats a pretty restrictive breakfast. Their thoughts are, I can't eat a lot today, gotta run well in track. Maybe it's someone in high school or college, and they're feeling pretty anxious. They restrict their morning snack, they skip it. And their thoughts are, I can't focus, but at least I'm in control. Emotionally, they're feeling distracted and controlled. Lunch, they eat a pretty restrictive lunch, maybe half a turkey and Swiss sandwich on wheat. Thoughts, no one wanted to sit with me. So maybe they're at lunch and just that no one was saving them a place, something like that. No one wanted to sit with me. I gotta lose more weight. I'm so ugly. Feeling rejected. We see this a lot, right? This kind of one of the functions of eating disorders might be a common one, I would say, is to be accepted, to be liked. And we see this a lot, this belief that if I look a certain way, then people will accept me, then they will like me. So at dinner, we're eating 5 slices of cheese pizza, a bag of potato chips, 10 Oreos. Thoughts, I'm so disgusting. No wonder no one likes me. And emotionally feeling disgusted, gross, and ashamed. Okay, so we like to use this information for, and typically you're going to have a week or 2 weeks worth of something like this, and you begin to see patterns kind of develop, right? And over time, you begin to help that client see, well, let's look at these thoughts. You know, no one wanted to sit with me, gotta lose more weight, I'm so ugly. And you bring out a list of cognitive distortions, and does this fit in anything? You know, it might be helping that client see, well, did you ask anybody if you could sit with them, right? There's a difference if people just happen to not notice that you had someone to sit with versus asking and them saying no, right? So helping our clients kind of work on these thoughts. I think I'm getting ahead of myself, but this is essentially what self-monitoring looks like. So in other phases of anorexia nervosa, we're implementing initial cognitive interventions. So such as what I just mentioned about introducing cognitive distortions. We're working on increasing the motivation for change, challenging cultural ideals as it relates to weight or shape and determining family involvement at this point. Then getting really into phase 2, sorry, I think I said phases before, getting into phase 2, we're working on changing beliefs related to food and weight, and then broadening the scope of therapy. So there's a continued emphasis on weight gain and normal eating, but we're also reframing relapses. We're identifying dysfunctional thoughts in this phase. So that might be where you take the self-monitoring into more of the deeper identifying dysfunctional thoughts. We're working on cognitive restructuring. So cognitive restructuring, this skill is huge. I use this all the time, even if I'm just doing it verbally. Can be done on paper or electronically, like I said. The client identifies an automatic thought, emotions, a cognitive distortion, and again, typically there's a list. My favorite list is in David Burns' book, Feeling Good, and he has a whole list of cognitive distortions and explanations. So it might be all or nothing thinking, catastrophizing, overgeneralization, that kind of thing. So we're identifying cognitive distortions, evidence for and against the automatic thought, and then we're working to restructure the thought based on that information. So one thing I want to be careful of that I tell all my clients is that it's not necessarily trying to replace a negative thought with a positive thought. I kind of call that trying to be Pollyanna. We're not trying to do that. We're just trying to reframe it so that the thought is no longer distorted. Maybe it's positive, the reframe is positive, maybe not. We're just trying to get the distortion out of it. So maybe it looks like this. No one wanted to sit with me since I'm so ugly and fat. Okay, what's the distortion? I'm kind of skipping a little bit just because I couldn't get everything on the slide. So I'm kind of skipping some of the emotions and all that. But what's the distortion? Mind reading, catastrophizing. It can be more than one, okay? Evidence for, well, evidence for that thought is that no one asked me to sit with them. Okay, so maybe I might let a client get away with saying that as evidence. I don't know that that's evidence that no one wanted to sit with the client, but we do have evidence that no one asked for the client to sit with them. Evidence against, no one else waited to be invited. They just sat down. No one has actually told me that I'm ugly and fat. So again, evidence against, well, it wasn't like anybody else in the cafeteria was just asking permission to sit down. They just plopped down their trays and sat down and started laughing and talking about something, you know? So maybe a restructured thought is, it feels bad that people don't reach out to me. Maybe they do not realize I'd like to be included. Lisa is nice. Maybe if I ask her if I can sit next to her, that would be okay. All right. So we're kind of restructuring this thought that it's validating that emotion. It does feel bad that nobody bothered to include me. Nobody went out of their way to include me. But it's also kind of pausing before we go to make assumptions from there. Maybe they don't realize I'd like to be included, right? And then it's kind of this kind of problem solving idea of, well, this person's pretty nice. Maybe if I ask her if I could sit next to her, that would be okay. All right. So we're also working on modifying the self-concept in anorexia nervosa. And this is also where we begin to develop an interpersonal focus in therapy, possibly involving the family. So we're going to be talking more about relationship with self and relationship with others in this aspect. In phase 3, so kind of toward the end of treatment, we're working on relapse prevention and preparing for termination. And in doing that, we're summarizing progress. We're reviewing the basics for continued progress. We're summarizing continued vulnerabilities, such as a common one for someone with anorexia nervosa in particular is change. So it could be a change in routine, could be a change in terms of living situation, a change in terms of a breakup or a marriage, something like that. Review warning signs. A warning sign might be, like a warning sign for relapse might be, I begin to look up diets. Okay, that could be a warning sign. I identify when to return to treatment, and that's kind of between the treatment team and the client of, what would be a good sign that I need to kind of resume therapy again. So that's kind of what you're doing in phase 3, relapse prevention and preparing for termination. In bulimia nervosa, we're going to see a lot of similarities here. It's also in 3 phases, and it's more so addressing the binge eating and compensatory behaviors. That's essentially what bulimia nervosa is. Individuals with bulimia nervosa is going to be more normal weight, and they always have binge eating and some compensatory mechanism. It could be purging or non-purging. Basically, purging, most common type of purging is self-induced vomiting, but it could also be laxatives, diuretics. In the case, of someone with type 1 diabetes, it might be misuse of insulin. But non-purging compensatory behaviors might be overexercise or fasting, something like that. So we're addressing the binge eating, compensatory behaviors. We're also addressing dietary restraint. This is one thing that just subjectively I kind of differentiate between bulimia nervosa and binge eating disorder in terms of the binge eating part, is that someone with bulimia nervosa is often still engaging in dietary restraint. And I see that a little bit less in binge eating disorder, but I'll get there. So dietary restraint and dysfunctional thoughts and feelings about the overvaluation of weight and shape. So much of this is very similar to anorexia. In phase 1, we're focusing on behavior change within the first few sessions. So we're doing self-monitoring, psychoeducation. We're also working on establishing regular eating patterns. So again, even though I'm not a dietitian and I want the dietitian to be the one to do the meal plan and all that, what I do know in bulimia nervosa is they need to be eating regularly. And I find, because often what happens is, not always, but most of the time, someone with bulimia nervosa is restricting their first part of the day. Maybe they binge the night before and they're saying, okay, I can't eat all day today or something like that. And so they're restricting breakfast, snack, lunch, and maybe their snack, but it's by that afternoon time, right, biology takes over and her bodies are so hungry. And so their body is trying to tell them, like, basically, feed me, but you've been going all day. And so what you tend to do is just say, okay, I'm only going to eat one. Well, then your body takes over, right? And so you eat more and more. And then by the evening, you're binge eating in the evenings, and then it's just this perpetual cycle the next day. Well, I binged last night, so I can't eat anything today. Side note, when I find that I do that and I ask someone, I'm like, I don't even really care what you eat, but I need you to be eating regularly every 3 to 4 hours at this point in phase 1, especially if I'm the first person seeing them. This will decrease binge eating by, I would say, close to 50%. Okay. There's still a lot more to work on, but this is biology. This is important. In phase 1, we're also working on self-control strategies for the behaviors around binging and purging. So surfing the urge, teaching someone when you have the urge to binge, or if you've already binged and you have the urge to purge or do the compensatory behavior, we want you to hold off for 20 to 30 minutes, do something highly distracting, and you give them some ideas, and then reevaluate where you are with that urge. In phase 2, we're focusing on reducing dietary restraint, continuing to work on that, and developing skills to resist binge eating with increasing cognitive focus. I didn't really do a separate slide on this, but I did bold this: eliminate dieting is huge. Okay, so especially focusing on reducing dietary restraint. We gotta eliminate dieting. And by dieting out, it doesn't have to be a formal diet, but just any kind of dietary restraint. We're teaching problem solving skills, again, going back into a lot of all or nothing thinking, catastrophizing, overgeneralization. So we're kind of teaching some different things. One thing I hear a lot from a lot of my clients who are teachers is, you don't understand, there is like no time during the day to eat a snack, and I'm not allowed to eat in front of my students and blah, blah, blah. Well, typically whenever we go through this a little bit more, we discover, there might be 3 to 5 minutes during the afternoon to get in, something like a mozzarella stick, something easy to eat. It does not have to be something that takes a lot of time and energy and effort, but just getting something in your system. And a lot of times when you feel close enough to another teacher or a principal, assistant principal, just to kind of maybe even ask for that special permission, it's granted. And a lot of times what I notice is that there's not really a, steadfast rule that you can't. It's just that most people don't. And so just learning how to take care of yourself in that way, right? So teaching problem solving skills, working on the cognitive restructuring in phase 2, and any other strategies to address shape and weight concerns. I might do a little bit increased body image work in this phase. In phase 3, very similar, we're doing relapse prevention and maintaining the changes that the individual has already been working on. We're anticipating future difficulties and preparing for ways of coping with them. And we have a written maintenance plan. So basically, what's been working for you? We want to keep doing that. In binge eating disorder, basically binge eating disorder is an individual who binges regularly, typically once a week for at least 3 months, and they do not do compensatory behaviors, okay? So it's also 3 phases, multiple steps addressing the behaviors, the cognitions. We're doing exposures with food and that kind of thing, because the treatment for binge eating disorder does not include any kind of dietary restraint around not allowed to have binge foods, right? We're developing skills and doing relapse prevention. So a lot of this, I know I'm going through this really fast, but a lot of the same things we've kind of talked about with anorexia and bulimia. In step 1, we are doing self-monitoring. Step 2, we're developing regular eating patterns. Step 3, we're identifying alternatives to binge eating. So this might be a little bit of a different thing. We're noticing, okay, what's the emotion that comes up? What are the thoughts? What can we do instead to address those thoughts and emotions? Or it might be to distract, again, for 30 minutes to an hour, right? Until that urge can kind of have time to subside. In step 4, we're working on problem solving, again, addressing a lot of those cognitive distortions and how we can have different perspectives. In step 5, we're reviewing progress and identifying other areas to address. We're definitely breaking any kind of residual dieting, if there is anything there. We're addressing poor body image, and we're working on relapse prevention around maintaining progress and addressing any setbacks. And that actually, I will pause there. In any of these phases with any of these eating disorders, addressing setbacks is really important. And there's a difference between a slip and a relapse. Relapse is kind of like a set of slips and ongoing, and like we're pretty quickly headed back to eating disorder. A slip is kind of maybe a one-time thing, or it becomes less frequent throughout the recovery process. And I oftentimes like to talk to clients about a slip is just, it gives us information. In some ways, this is great. We can learn from this. How can we grow from this, right? So addressing setbacks might be addressing slips in a way that's really normalizing it. So I, again, just absolutely love CBT. It's evidence-based, in particular for bulimia nervosa. And there's also a lot of good evidence for work with binge eating disorder. And I think that there's a lot of components that can really be helpful for someone with anorexia nervosa, especially depending on where they are in their recovery, especially if they're newer in recovery. So it's a great intro therapy for anyone who's new to eating disorder treatment. So if you're a provider and you haven't worked much with eating disorders, this is a great starting place. Just begin honing your cognitive behavioral practices for your clients. I love it because it really addresses the behavioral and cognitive aspects of recovery from the very beginning and provides a framework for reduction of behaviors while also cultivating new perspectives. And in doing this, the client can then work on more validation and acceptance of the emotions. So there you go. Let me go ahead and stop sharing and I can join you guys again. Okay, cool, great. So that was just kind of like we're dipping our toe in the water of cognitive behavioral therapy and eating disorders. I hope it gave you some information that was maybe new or just very helpful, or maybe it just validated what you're already doing in working with eating disorders, whether it's with a client or if you're working on this with your own therapist. So hopefully you found it helpful, and thank you so much for taking time out of your day to listen. I appreciate it.